So let's say we're looking at this image, and this is an autopsy type of image. It's pretty evident that this patient has very thick pleural region. In the clinical vignette where this image was presented, they gave some constitutional-like symptoms, right? Fever, fatigue, weight loss. So I can say that this patient must have had some issue with mesothelioma. Basically, mesothelioma would make sense. Now, if we're going to test the tissue to confirm specifically what cell originated with this malignancy, we check something called intermediate filaments. Intermediate filaments, these are clues that you'll see in questions that they'll throw at you in order for you to understand the primary tissue that had the malignancy problem, right? Because remember, we have metastasis, we have cells that can migrate to different areas and definitely generate some kind of malignancy, but we want to know where these problems originated from. You can always check intermediate filaments. So let me explain to you what that is. In all reality, every cell, once they differentiate, these cells have this area right here, right? So not really the desmosome. We're looking at this area here, this thing that looks very wide. It's making the cell stable. It makes the cell not flop, not fall into itself. So that way the external pressure can leave the cell. The morphology of the cell is stable. So that's the intermediate filaments. This is part of the cytoskeleton. Remember, cytoskeleton has microtubules, intermediate filaments, and you have actin, these kind of elements. Intermediate filaments, for different tissue, you have different type of filaments. That's all I'm trying to tell you. So for example, if we're looking at epithelium, you have keratin. So they call it cytokeratin. So that's what you'll see at the level of a mesothelioma. At a histological level, mesothelioma is made up of epithelioid and sarcoma-like cells. So they look extremely similar to epithelium and spindle-shaped cells. So you'll see that the intermediate filament that are predominant will be cytokeratin. But I'm also going to include another type. You're also going to see something called calretinin. Okay, calretinin. This is something else that you'll see. It'll be positive for calretinin. They'll be able to stain this. Keep that in mind when it comes to intermediate filaments. Remember, intermediate filaments can be found with different tissues. For example, glial tissues. If you're looking at something from neuroglia, remember we have GFAP, will be that same type of intermediate filament, but found in neuroglial cells. Okay, in neurons, you have neural filament. So they kept that one easy for you. They didn't give you a weird name there. Let me open the chat just in case you guys have any questions. I'm open to questions at all times. Okay, so yes, also for muscle cells, you have something called desmin. So any type of muscle malignancy or any problem with the muscle, you'll see that the intermediate filaments are called desmin. So they tell you that there's a deposition of cells with abundant desmin as the intermediate filament, then you know it's a problem with the muscle system. Now, the mesenchyme, the connective tissue that you can find, that'll be pimentin. You don't have to worry if you don't have this on your notes because I'll make notes and I'll post this up as well. Oh yeah, something I should add to the intermediate filaments. Remember that even the nucleus has an intermediate filament. Nuclear structure, it can break down. So it also has intermediate filament. And that's something called lamin. Remember that mutations in the gene that codes for lamin can cause progeria. Progeria, this is that disease that these kids look like they're getting really old really fast. You remember that? It's a spontaneous mutation within their genes and they get this problem. So remember that. That's the cause of it, basically, a mutation in that sense. Okay, so these are the types of intermediate filaments that you would find. That's how we identify specifically what cell had the issue. Okay, so if this person had a mesothelioma, we can assume that his exposure to asbestos must have been abundant, right? Asbestos. So asbestos is a carcinogen that can predispose the patient to mesothelioma. But we should also understand that not only mesothelioma, remember one thing, this asbestos most commonly will have the proclivity to cause a bronchogenic carcinoma over a mesothelioma. So let's be very clear here. Bronchogenic carcinoma will have a higher proclivity, higher relationship with asbestos than mesothelioma. So what kind of occupational exposure is related to asbestos? These are patients, well, let's say people who are working in roofing. These are people who are working in mining, shipbuilding, installation. They install insulation units in houses. These kind of patients are prone to asbestos, okay? Keep that in mind. That's very important. Now, I'm also going to tell you, remember that lung cancer is the most fatal cancer, right? We went through that yesterday. We spoke about fatal cancer. We said lung cancer is very fatal. And we mentioned that it has collateral irrigation, that it can metastasize very easily. Okay, we understand that. But I should tell you, when do we actually screen a patient for lung cancer? So are we screening everybody? No, we're not. So which patients are specifically screened? In the United States, what is the guideline? Patients who we deem to have a high risk for lung cancer are those between the age of 55 and 74. And they have a 30-pack a year smoking history. They have not quit within the last 15 years. Okay? So you're looking at their timeline. 15 years, they're not cleared. They haven't cleared up those 15 years. If 10 years ago they were smoking 30-pack a year, this patient qualifies for screening, right? You want to screen the patient for lung cancer at that point. So that's the typical screening that we do for these type of patients. Keep that in mind. Now, let me tell you, cigarette smoking goes hand in hand. It's basically a super strong carcinogen when it comes to lung cancer. But guess what? Second place will be something called radon. Yes, colorless, doesn't even have a smell, and it's a radioactive gas. Whenever you break down uranium, you produce this. So this basically makes its way, seeps its way through the basement. And it's abundant in some basements, and it can cause patients to have lung cancer. So keep that one in mind as well, right? So second place carcinogen is radon, seeps into the basements. All right, so let's continue. Malignant mesothelioma. Last thing I should say, you can have spindle type of cells, they'll tell you. Spindle cells. So what do they mean with spindle cells? You guys probably heard this type of histological description. They say that these cells are displayed in a whorl-like pattern, like a whorl. They're basically talking about psammoma bodies. You guys probably seen them before. So how do we identify psammoma bodies? Spindle cells arranged in a whorled pattern. Laminated calcifications. These are different descriptions. So be careful and do not confuse this whorl-like pattern description with silicosis, because the histological description of silicosis involves nodules composed of whorled collagen fibers and dust-laden macrophages. So you still have a whorled pattern, but it's made up of collagen. Okay? So histology is one of those subjects where you have to see it enough in order to understand it properly. And you have to look at their descriptions. And then those keywords, those buzzwords start to click. So these are two different types of descriptions that I've seen before in questions when they try to describe psammoma bodies. So yes, these are psammoma bodies. This is how they look. And you can find psammoma bodies in different types of cancers. Can anybody mention one other type of malignancy where you can see psammoma bodies? Anybody? Type it in. Let's go. Where else can I see psammoma bodies? Papillary carcinoma of the thyroid. Oh, okay. So you're saying ovarian. Ovarian, let's be specific. Serous papillary cystadenoma of the ovaries. Yes. Yes, yes. Definitely. That's good. So yes, the mnemonic that we have is like a psammoma. I know there's a couple more that have been added to this type of mnemonic. PSMM, psammoma. This one goes in nicely. Meningiomas. Yes. Meningiomas. Yes. When I look at psammoma bodies, for some odd reason, it kind of looks like a rose. Look at that. You see the similarities to that? I mean, I might be the crazy one here, and I see it as a rose. Whenever I look at that, I can say, well, they look like drawn roses. And I mean, I can compare it to different images as well. So this is not just one image. Let's look at a couple of them. We look at it here as well. Look. Looks like a well-developed type of rose. We're looking at it from an aerial view, looking at it straight down. You can see that it looks like a rose. I see it that way, and I'm able to just distinguish from anything and say, okay, that is a psammoma body. So here I'm going to show you even with different colors. They kind of look that way. All right. So keep that in mind when it comes to distinguishing this histological feature. We will go through a lot of histology and we will make sense of it. Now, the best way to understand histology is to relate it to something that you already know. You can distinguish it whenever you look at it. You'll be able to tell, okay, this is a clue for such thing. For example, in squamous problems, you have those nest, and we'll see that as well. All right, so we went into the next subject. We were talking about sarcoidosis. Basically, today I did a video today on sarcoidosis. Sarcoidosis, of course, it's one of those type of diseases that's very high yield. You'll see it everywhere. One thing I should tell you about sarcoidosis, Whenever they mention sarcoidosis, it's going to be a situation where you have an African-American young woman with bilateral hilar adenopathy, right? That's typically what you see. You'll see something like this. And that'll make sense. But of course, they have to tell you about these constitutional like symptoms. They have to tell you that this patient has night sweats, she's losing weight, she has fatigue, she has all those type of symptoms that really kind of make you think of a cancer. But one way that you can differentiate it very easily, think about it. Sarcoidosis is bilateral. You'll see that bilateral problem. Very difficult for you to have some kind of bilateral cancer, let's say some tumor that's occupying the same exact areas on both sides, right? Less like a symmetrical type of deposition of malignant cells. So that really tells me the difference between those two. Now, there's a lot of systemic type of symptoms as well. You'll see a lot of systemic problems with these patients. Let's mention a couple, for example. And this can be more confusing because they can exaggerate one of these problems and try to confuse you with it. For example, interstitial infiltrates still get into the restrictive lung disease pattern. Now, why is this a restrictive type of lung disease? The whole pathophysiology of sarcoidosis is the idea of forming granulomas. Remember the formation of granulomas. Hopefully you guys can remember how that happens, the cytokines that are responsible. Typically, when it's an original type of granuloma formation, when we look at bacteria, especially like gram-negative bacteria, is going to be LPS. LPS makes contact with a macrophage. Macrophage has its toll-like receptor. Once these two things make contact, they release NFK beta. NFK beta is an immune modulator that's able to stimulate these type of cytokines. You have tumor necrosis factor alpha, IL-1, IL-2, IL-6, 8, and 12. This is what typically happens. Now, in gram-negative, we mentioned LPS. If this was a gram-positive, it will be something called teichoic acid. It's going to make contact with that toll-like receptor. This is the toll-like receptor right here. Okay, we understand that. That's whenever we're talking about a PAMP, pathogen-associated molecular protein. But you can also have something called DAMP, damage-associated molecular protein, which will engage an inflammatory response similar to this in order to produce a localized kind of inflammation. In the essence of sarcoidosis, where you are basically able to have macrophages release NFK beta and then have this cascade of all these cytokines secreted. Tumor necrosis factor alpha, IL-1, IL-2. So what are these things responsible for? Remember that IL-1 is responsible for fever, right? For increasing the body temperature. IL-2, remember, is responsible for more T cell proliferation. IL-6 is an acute phase reactant cytokine, which means it'll stimulate acute phase reactants. It will make its way into the liver and stimulate different types of proteins to get the body ready for an acute inflammatory response. Like proteins like hepcidin, a lot of different proteins involved here. IL-8 is a chemotactic type of protein. This here will attract more neutrophils to the localized area. You're telling the body, hey, we have an inflammatory issue. We need neutrophils. And that's a big thing here when it comes to chemotaxis. You should know the chemotactic factors. Chemotactic factors used to be very easy, but they have added on a bit more chemotactic factors. So I made a nice little list here. These are the actual proteins involved in chemotaxis. So my mnemonic was silk, and that was enough back in the day. That was good enough. But now you also need to know platelet activating factor and N-formyl methionine peptides. Okay, these are chemotactic factors. So it says here, fever, T cells, inflammation, and fever too. Well, yes, you see how the patient with sarcoidosis has these constitutional-like symptoms, fatigue, tiredness, fever as well. That's why C5a also is in there. Those are chemotactic factors. Good. Definitely. So, okay. If you are interested in one-on-one drills, individualized specifically for you, where we go over a lot of material based on UWorld, MBME, first aid, etc., contact me via email. My email is in the description below. Thank you, and let's continue. But in sarcoidosis, notice what happens. This is not an actual, let's say, a natural provocation of a granuloma formation. There is no kind of pathogen that's being attacked. There is no particular type of pathogen that these macrophages are trying to surround. typically when you do have a pathogen, let's say after you release that NFK beta, you released all these different types of cytokines. What would eventually end up happening is that this macrophage, let's say antigen presenting cell, is able to activate. And it activates with CD4 T cells. CD4 T cells will allow activation. Well, when you activate, what happens? Well, when you activate, you're able to then turn these CD4 positive cells. Remember, you can either have Th2 or Th1. Here, you're going to promote Th1, mainly because of the IL-12 that we saw on that list. IL-12 was in that list. So IL-12 enforces the differentiation of those T helper cells basically into Th1. So now that you have your Th1, let's say, what ends up happening here? You're able to then release interferon gamma. Interferon gamma is it has great importance. Why? Because it's responsible for the recruitment of macrophages. Remember, it's produced by the Th1. Once this Th1 is active, you'll see that it's going to stimulate macrophages. So macrophages will make its way into that pathogen. It'll say, okay, well, you guys need help. That's what it believes. It believes that help is needed. So let's see what's going on. If this was a real pathogen, let's just give the example that this is actually a pathogen here. Macrophage made contact with some kind of pathogen, and we were able to make a whole bunch of Th1 utilizing IL-12. Let's say that's the case. That's the scenario. If that's the scenario, then Th1 will release interferon gamma, like we said. Interferon gamma will recruit more macrophages. So more macrophages will come around and surround the threat. It will surround the threat. And whenever it activates, it turns into an epithelioid cell. That's how they call it. They're giant cells. They're growing in size. They're joining together. These macrophages are getting really big, right? And to keep this party going, they have to release tumor necrosis factor alpha. You have to continuously release more and more tumor necrosis factor alpha in order to keep this macrophages from going and surrounding the threat, right? This is what typically entails the idea of having a granuloma, okay? This is what typically we look at. All right, let's see. Interferon gamma mainly attacks viruses and tumor cells. Well, in this sense, I'll explain. Typically, when we look at viruses and we look at tumor cells, we're looking at CD8 positive cells and natural killer cells as well. Natural killer. So cytotoxic T cells are the ones that are attacking viruses and malignancies. Okay, normally that's what's going on. Here, I'm talking to you about a pathogen like a bacteria, like a tuberculosis, for example. This is what will basically form. You'll have this ganging up on the pathogen, surrounding it, activating itself, creating these epithelioid cells, and they end up surrounding the threat. And with time, yeah, there's like a battle going on in there. So what ends up happening is that there's necrotic deposition, because yes, you are attacking whatever's in there, and you get necrotic deposition. So that's an official granuloma. But remember, when we're talking about sarcoidosis here, there is no pathogen. This is just something that got activated. So what ends up happening is that you have non-casating granulomas. There's no real, like, who are we attacking? You see what I'm trying to say? So there is no consumption of a pathogen inside that granuloma. It's just a perpetual activation of macrophages surrounding one area. And this can be a problem because these macrophages gang up. They come in sizes, and then they start to deposit themselves within that tissue, that area. So if they deposit themselves, for example, in the lungs, they cause these non-casating granulomas. So they start to mess with the lung tissue, causing damage, causing pro-inflammatory response. And if you have a pro-inflammatory response to the parenchyma of the lungs, you end up having fibrotic deposition. So you cause a fibrosis. And if you cause a fibrosis to the lungs, remember the rule, we're causing a fibrosis to the lungs, then we're decreasing the compliance. So we're basically causing a restrictive lung disease. Because remember, the idea of compliance was the idea of having oxygen inside a tissue. And if this tissue cannot stretch properly, then you can't put oxygen in that tissue. So by having fibrosis, you're having the replacement of lung parenchyma with this collagen-like tissue that really wasn't made to hold oxygen or to stretch. So what ends up happening, remember, when we look at compliance, the formula basically was volume, change in volume, and over the change in pressure. So we're here having now a decrease in compliance. So you're now having a decrease in volume. And that's the problem with a restrictive type of disorder, right? You have decrease in volume, basically the opposite of an obstructive type of disorder where you have an increase in residual volumes and other types of lung volumes. Does that make sense? Right? That makes sense so far. And notice one thing, in a real threat, if I give a drug that inhibits tumor necrosis factor alpha, then this whole granuloma setup that I have here gets destroyed. And whatever we are attacking, let's say we had a tuberculosis under attack, and the tuberculosis was avoiding attack, it had a cord factor, it had all these types of its toxins to avoid damage. If we gave something that inhibits tumor necrosis factor alpha, like infliximab, then that TB can now escape this damage and now it can disseminate and cause problems in other places. So remember, if a patient, for example, if you suspect a patient to have made contact or can have a probable tuberculosis, and you're going to treat a Crohn's patient with infliximab, you should make sure, right, that this patient does not have any kind of active TB or anything like that. Because if you give infliximab, you'll stop the whole granuloma formation, and then you'll have dissemination of that TB, okay? All right, good. So yes, that's a problem in the lungs. Fibrotic lungs is going to cause a restrictive type of pattern. We can see this with drugs as well. There's drugs, of course, that cause pulmonary fibrosis. So one of the drugs that I'll mention is bleomycin, right? Remember, bleomycin is used in situations of testicular cancer. It's also used in Hodgkin lymphoma. So what is the mechanism of action of bleomycin? We should understand that certain types of oncotic drugs, they tend to cause havoc. So you give this drug, let's say the strategy that this person, let's say the doctor is thinking of is saying, hey, I'm going to give a medication that has affinity for some type of tissue. And chances are it's going to destroy a lot of that tissue. We're hoping that the tissue that gets destroyed is that same type of cells that have malignancy. So bleomycin, basically, its mechanism of action is that it induces free radical formation, breaking the DNA strands. So wherever it has its affinity to, that can be seen as a big problem. It's basically, you're giving a poison, basically, if you think about it. You're giving something that destroys tissue. So it can cause pulmonary fibrosis as well. What else? There's also another drug called busulfan. And this one, instead of just causing free radical damage, it actually cross-links DNA. Cross-links DNA. Methotrexate as well. Good. So can you tell me then the mechanism of action of methotrexate? Do you know the mechanism of action? Anybody? If you know it, type it in. How does methotrexate work? What does it do? Halts folate. Okay, well, I'll tell you. Remember that, well, it does in a sense because you have dihydrofolate, and you have to have dihydrofolate become tetrahydrofolate in this type of cycle where you're making your nucleotides. Remember, you're making your thymidine. You're utilizing uridine monophosphate, dioxyuridine monophosphate. You're trying to turn it into thymidine. And this is done is catalyzed by an enzyme called thalidomide synthase, right? This is such an important step because it's related to so much pharmacology just in this one step. So there's something called dihydrofolate reductase. And yes, you are right. So it inhibits dihydrofolate reductase. That's the right way that we go by it, reductase. And if you inhibit dihydrofolate reductase, then you cannot replenish the folic acid to have your tetrahydrofolate. So that's the issue there for methotrexate. Methotrexate is a drug that we use for humans, right? This same mechanism can be used for different types of species. All right, so ignore that top step with PABA and pteridine. That's how sulfamethoxazole works and sulfadiazine. They stop that dihydroteroate synthase in prokaryotic cells. Here, we're talking about humans. So methotrexate on humans, yes, it will inhibit the dihydrofolate reductase right here, as you can see. Same thing happens with trimethoprim in bacterial cells. Pyrimethamine is used in parasites to be specific in toxoplasma. Remember toxoplasmosis. You can use sulfadiazine and pyrimethamine. Ring-enhancing lesions on brain imaging. Remember, patients with HIV. Yes, typically this is what you see in that sense, okay? So keep that in mind. All right, we continue. Oh yeah, so there's proguanil. You probably heard of that medication before. It does the same thing, but it does this for malarial species. So for malaria, if you want the same reaction, proguanil can do this. So yeah, methotrexate was another drug that can also cause this pulmonary fibrosis. There's one called carmustine as well. Notice how there are a lot of like oncology types of drugs. Carmustine, and there's also another one, of course, and this is amiodarone. Amiodarone. So who can tell me what amiodarone does? How do we use amiodarone for? So you're saying arrhythmias for amiodarone. I'm going to ask you then, what type of antiarrhythmic drug is this? What, for example, what phase? How does this work? Do you remember? Okay, so you're saying potassium channel blocker. Okay, perfect. So if we look at it like this, remember you have pacemaker cells and non-pacemaker cells. Remember you have those two different types of cells. For the non-pacemaker cells, they do have these phases that they have to go through. You have phase 0, where you have voltage-gated sodium channels. You have your phase 1, where these voltage-gated sodium channels close, and then these potassium channels briefly open. Then you have your plateau phase, where you have calcium coming in. And then you have two types of potassium channels that are active: the slow delayed recidifier channel and then the rapid delay recidifier channel. They're just two potassium channels that allow repolarization. So the phases are here: 0, 1, 2, and 3. So basically what you're telling me is that amiodarone, it's able to close down these type of potassium channels and prolong the repolarization phase, right? Repolarization phase of ventricular action potential. Yes, correct. So what is the potential side effect that you can get? Think about it. Phase 0 represents a QRS. Well, another side effect, let's say at a level of an EKG, a cardiotoxic effect that can be caused by amiodarone. Remember, this is now the T wave. This is QRS. This is a T wave. Thyroid problem, torsades. Yes, Cindy. Yes, yes, yes. Although, yes, you can have thyroid problem. Of course, you have to check your thyroid labs before even giving this type of drug, and then recheck them again to see if the thyroid levels are changing. Definitely. But one thing that is very, very important, and this is why cardio is such an important subject, because cardiotoxic effects are potential, yes, TFTs, PFTs, and LFTs. Definitely. You have to check to make sure that everything is functional. Everything is good. And yes, we talked about this before, actually. We mentioned the idea of damage versus function. I don't know if you remember that we said those are two different things, that you can literally look at some kind of like viscera and try to measure the damage in comparison to the functionality to see what is taking a hit. But yeah, definitely. For example, one of the cardiotoxic effects that we do need to be aware of 100% is the QT prolongation. QT prolongation. That can lead to polymorphic ventricular arrhythmias known as torsades de pointe. Why am I always going on about these kind of cardiotoxic effects? Well, because these are the potential fatal side effects, right? And that's what we do need to understand 100%. Fatal side effects. All these other things there, oh, you get them off the drug. What's the next step in management? If you see that LFTs are increasing, go get them off the drug, switch them off to another antiarrhythmic, right? But if you have a patient who has torsades, what do I do? What's the treatment for torsades de pointe? Can anybody tell me? Okay, magnesium. Yes. Before anything though, I want to check if the patient is hemodynamically stable, always. What do I do if the patient is not hemodynamically stable? What is the management of that case for torsades? Can anybody tell me? It's a ventricular arrhythmia. Remember that. It's a ventricular arrhythmia, not a supraventricular. Let's go. Let's go. You guys got this. What exactly is hemodynamically stable? BP under, let's say, systolic pressure under 90. diastolic pressure under 60, systolic blood pressure under 90. Okay, so if that's the case, I'm going to go for the defibrillator, right? So defibrillation. So let's be clear about one thing. Ventricular arrhythmias are not something that can be played with. Whenever the patient is undergoing ventricular arrhythmias and they are losing their hemodynamic stability, we can utilize defibrillation in order to get them back into a proper conduction. Now, if it's a supraventricular tachycardia, which is different, if it's a supraventricular tachycardia, you'll see that the QRS will be narrow. It will be narrow, less than 3 boxes. And if that's the case, we can go for cardioversion, right? Cardioversion. Cardioversion follows a shock that follows the cardiac cycle. So it goes through the cardiac cycle, the atrial contraction and the filling phase and the ventricular contraction, isovolumetric contraction. Like it tries to follow that to bring that back. That's what it tries to do. Okay. Good. This is the wonderful thing about the drills. We start off with lungs and now look at where we're at. We're literally talking about management of cardio. So yeah, let's continue. Let's get back into the lung system, right? We can't stray away for too long. Okay. So like we were mentioning, we said sarcoidosis. One last thing I would say though about sarcoidosis is that sarcoidosis, same mechanism of the deposition of non-casating granulomas, can cause a cardiotoxic effect. And this is something that we do need to understand. Cardiotoxic effect. So you can have deposition of non-casating granulomas on the heart. And remember that the heart has a very specific type of conduction system, bringing conduction from the SA node all the way to the AV node. And if we start having some kind of fibrosis within this, let's say, communication between these two, then it's going to have a problem depolarizing this. It's going to have an issue with the depolarization. So I'll tell you 2 cardio effects that you can have. One of them can be ventricular arrhythmias. Why? Because of what I just drew right here. If you have fibrosis, you're going to have a haphazard, unorganized type of conduction coming from the SA node to the AV node. It'll be completely disorganized. And that's what basically the definition of an arrhythmia is. Uncoordinated type of depolarization, right? That makes sense. So not only that, that's one issue that you can have. But if, let's say, you have no conduction going to the AV node from the SA node because there's so much scar deposition left from the non-casating granulomas, well, guess what? Now you can have complete AV heart block. Heart block can happen. And yes, this is severe. Patients might need to have basically a pacemaker on this sense. Okay, so that's called cardiac sarcoidosis, and that's potentially fatal. Keep that in mind. That is potentially fatal. Now, what happens if the conduction system is not affected? If the conduction system is not affected, if the pacemaker cells are not affected at all, pacemakers are checking out and they're good, you can have a problem basically on the non-pacemaker cells. Non-pacemaker cells are the cells that make up the cardiac tissue, right? Like the ventricular cells, the cells that are responsible for the contraction, the relaxation, the chambers, basically. So what happens if you have non-pacemaker invasion of non-casating granulomas? Well, I'll tell you. It starts off with a restrictive cardiomyopathy. Yeah, you will have dilated cardiomyopathy. You are right. But at first, in the beginning, it starts off restrictive. At first, you have restrictive. The deposition of the non-casating granulomas makes it hard for that tissue to relax. Same thing happens in the lungs. Remember that. Same thing happens with the deposition of fibrosis. You have an improper diastole. You have a diastolic dysfunction. So your ejection fraction is increased more than 55, yet you're still having some kind of heart failure, some kind of problem here. That's going to be a restrictive cardiomyopathy. That's how it starts. But yeah, you are right, Khadija. Why? Because as this continues, the integrity of those cells are damaged. And you'll then start to see that the heart itself starts to then expand. It starts to get floppy. And then we're entering the territory of dilated cardiomyopathy. So it starts off restrictive. How would fibrotic restrictive turn dilated? Oh yeah, I'll tell you. So All right, so let's see if we look at the integrity of the tissue itself. Let's say this tissue is very stiff. The fact that the tissue is stiff, this heart cell, let's say, remember, heart cells are syncytial. They have gap junctions. One cell would activate the next cell, right? That's how they function. They are communicating one with another. So they still have to do their job. Even though they have fibrotic deposition among them, they still have to do a proper systole. And with time, you're using a faulty equipment to try to produce proper cardiac cycles. And that tissue will have so much strain on it that it'll basically represent more and more damage, functional damage, where the sarcomere starts to take a hit. And then you'll start to see it as a dilated cardiomyopathy. It starts to get floppy, right? Because you got to remember, these heart cells, even though they have deposition, they still have to do their cycles of depolarization, repolarization, systole, diastole, with all that deposition on them. So at first, yes, this is a restrictive problem, but with time, their functionality starts to decrease. And then you'll start to see them dilate. Then it goes from a diastolic problem to a systolic problem. Okay, and that will be evident once it turns into a dilated cardiomyopathy. You can hear an S3. Right? That makes sense. Good. That's the great thing about this topic. We're jumping everywhere. We're making sense of everything. So since sarcoidosis is actually an immune problem, we want to give steroids, right? Okay. So something else that we should mention as well is that these kind of granulomas, they have these activated macrophages, and activated macrophages can actually have 1-alpha hydroxylase. 1-alpha hydroxylase can promote basically can promote 25 cholecalciferol, basically, to turn into 125 cholecalciferol. So you start to now make vitamin D. You start to increase your vitamin D. These granulomas can tend to increase vitamin D. So what ends up happening? So this is very bad, because now a patient with sarcoidosis who have made these non-caseating granulomas are having a higher level of calcium within the circulation. And that is very dangerous. Calcium can do so many different types of things. Try to remember one thing. If we try to understand this, calcium can desensitize the tubules when it comes to ADH. So ADH will try to do its job on the kidneys, but the overwhelming increase of calcium will now not allow it to. So therefore, your patient will have polyuria, polydipsia. Your patient will be urinating a lot. So increasing calcium can cause these types of problems, right? Where you have now a patient who has a nephrogenic type of issue with ADH, right? He's desensitized completely. That's something that can happen with increased level of calcium. So keep that in mind. And you can have different increase of levels of calcium for different reasons. Today, we were also going to talk about squamous cell carcinoma of the lungs. And squamous cell carcinoma is huge when it comes to the release of PTHrP. You were able to catch the whole video. Thank you for tuning in. And if you want a personalized drill for yourself, make sure to contact me on my email. Email is in the description. Thank you. Appreciate it. Catch you next time with the next episode. Good luck in your studies.